Okay. So shall we begin? So good afternoon. Today is February the 9th, 2022, and it is 1:11 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, some of our committee members are also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication. We would normally receive public communication for both the Eastern Crescent Subcommittee and the Strategic Planning Committee before the Eastern Crescent Subcommittee meeting, but that meeting had to be canceled today. If you were planning on commenting on any of the Eastern Crescent items, please proceed with your comments, as the Strategic Planning Committee will be hearing item 1 from the subcommittee agenda. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Yesenia, did anyone register to make comments?
No, Madam Vice Chair, nobody signed up on the phone or online or in person.
Thank you. So since there are no comments today, we will now proceed to the committee agenda. So members, we will now take up item 1 from the Eastern Crescent Subcommittee agenda. Because that subcommittee is an arm of this committee, we can take up their work as part of our agenda. And that item is to receive and discuss updates on Eastern Travis County service expansion, and Stephanie McDonald will be presenting.
Thank you, Chair Brinson. Thank you, managers. It is my privilege to give you a really exciting update. We are on the cusp of construction for both the Dell Valley and Hornsby Bend sites. And Brianna, if you can go ahead and advance the presentation, if you'll go ahead and just go ahead and advance to the timeline, about 3 slides in. Sorry, a couple more. There we go. So Hornsby Bend and right now Dell Valley are on very similar timelines. We are in the permitting process for both projects. They have separate processes because Hornsby Bend is solely in the ETJ and not in the limited purpose annexation area of the city of Austin. It has a slightly different review process. It does also have a different water partner, and we are going through a little bit different route to try to get the water service there through the Southwest Water Corporation. So we are putting these timelines essentially on the same path forward, even though Hornsby Bend, because of its size and because of the different review process, may actually finish in advance of this timeline. If you look at the timeline, we are looking at the first client seen in the clinics sometime late spring of next year. And we know that with the supply chain disruptions and a lot of the lead times for furniture, fixtures, and equipment, that we're making plans and getting those items ordered early. But we just want to be very conservative and respectful of the community and their expectation, knowing that we have to get all of these pieces in place. So ideally, we would be seeing patients at the Hornsby Bend site offering health and wellness programming in advance of June of 2023. But we'd like to give ourselves a little bit of cushion, knowing that there's a lot of turmoil in the world right now, as we know. And I know having just gone through the ice storm as well as the boil water notice in the city of Austin, we are doing a lot of work to make sure that there are resiliency measures in place at the site, and that we're starting to develop with the community some of the amenities as well as some discussion around the future use of the site and the community partnerships that could be available, especially as we try to respond to some of these outside events that really require us to think about this site as a community resource, not just a health center. Brianna, if you can advance the slides. This is just a review of where we are at. I think many of you know that it's across the street from Daly Middle School. Next slide. Just some of the renderings from the architects. I think many of you have seen these, but just so that people know, we have a really, I think, good looking facility coming along. Next slide, please. And if you'll go to one more, there's a site plan. There you go. Just so people are aware in the community, we are looking in this first phase to build the Health and Wellness Center. We are working right now on how that will operate and what kind of partnerships and programming. I'll talk a little bit more about that in a minute. We will also have some other amenities, including, we hope, a play feature. David and the legal team are working with me on that. And then there's also a fitness trail, a crushed granite trail in the back in that wooded area that is adjacent to the neighborhood. Next slide, please. This is just the floor plan. The purple area or the light lavender area is where the Health and Wellness Center, the wellness programming and the community center programs and offices will be located. We hope to have or intend to have community workstations. There's one of the things that we have learned through the Guidehouse work, as well as other research, is that there is a lot of need for not just computer access, but high-speed internet access. And we hope that we can provide that at the community, for the community, regardless of if they're in need of the health services. A conference room also available to the community, and a large multi-purpose room. Offices that will have, we believe, MAP eligibility, as well as other community partners housed there. And there's an outside entrance, which will allow us to use this side of the building separate from the health clinic on the other side, which is in kind of the green area. The yellow area up front is kind of the common waiting room area. And then the reddish peach area is the back of the house, essentially. Next slide. If you'll just advance through the next few slides, Brianna, as I just talk, we do have a general contractor. The general contractor is on board for this project. We've already begun having owner-architect contractor meetings. I think everyone is excited. We expect to have a construction sign go up soon. And I think the next part is really working with the Community Advisory Committee and other community members and MAP and patients of community care in the area to talk about partnerships and services, as well as some of the additional community input that we'd like to see for the exterior amenities. We are having an advisory committee meeting tomorrow night, if I'm correct. And there's also work going on to plan for a groundbreaking event. One more slide. So just so that you're aware, we're meeting with the Community Advisory Committee meeting tomorrow evening, and then we are planning on a late March groundbreaking for the Hornsby Bend site. And we'll work with the Community Advisory Committee as well as other community members in planning that event. We'd really like to see it as being a resource event, trying to get some more input from the community, as well as I think at this point, everyone will be really excited about being outside and together, and that is our goal, to have a community event that celebrates this milestone, as well as getting a good sense of the community, what they'd like to see happen at the site and how they'd like the site to function. And I think it's really, really exciting. I'm very appreciative of the work that Yesenia Ramos and Yvonne Davila's team are putting towards this event. Next is Dell Valley, and it's, like I said, on a very similar timeline. Brianna, if you'll just advance, I think some of this is just background information. The schedule, like I said, is very similar, and this site is a little bit larger. It will be, it's about 15,000 square feet, and most of it is dedicated to Health and Wellness Center. We are still working on an unfinished area that we have a kind of a core and shell approach to, and are working, to develop a way to have more discussion about how that piece interior space is utilized. And we've had some interest already from some of our community partners in using that space. Next slide, please. This site is adjacent to Popham Elementary School and at Elroy and Ross Roads. And it has, you can advance, the site, the property just behind us has been bought by the Elroy Library District. And so it will be exciting that there will be a library next to the Health and Wellness Center. Exterior rendering here, again, we have a general contractor on board for this site. Really excited. The owner architect contractor meetings have commenced for this project as well. We are in active review and have gone back and forth in terms of with the city and Travis County and making sure that we are doing everything we can do to get those site plan and building permits released as soon as possible. Brianna, if you'll just keep advancing. Exterior rendering there, a site plan as well. This site will have a drive-through pharmacy. That drive-through pharmacy is in the green up in the top right of your screen. This will be a retail pharmacy. Most of community care's pharmacies are retail pharmacies, but in this case, we really do hope, because there's not a lot of pharmacy access in this area, that we will attract anybody in the area who would like to have their prescriptions filled closer to home, and they can get them filled at the site. This will be the first drive-through pharmacy, so hopefully it will go well and we can think about future drive-through pharmacies as part of our business model. Next slide, please. Just more of the lobby. This site will have dental, a lot of pediatric presence, and I think will be, more, it will have a multi-purpose room in the front area, but will be really filled with health and wellness center, health clinical services. Next slide. There's some of the interior dental renderings. Next slide, please. Special area for the kids. Got some feedback that we might need to have screens installed in the ceiling to show age-appropriate shows. Next, thanks, Brianna. We can stop sharing my presentation, and I'm happy to answer any questions. This is obviously a team effort, and kudos to Rachel Toronjo and our consultant team for getting us to this place right now. Lots of moving parts, like I said, and we are very hopeful. Whatever you do to bring on good luck, we need right now to make sure that we can get through the permit process as quickly as we can.
I have a question.
Yes.
Stephanie, Madam Chair?
Yes.
This is Cynthia Valadez, and it makes it difficult because I'm apparently looking at a little bit different presentation because I have a hard copy and not on a computer. And so I just wanted to be clear that you said it was a retail pharmacy, available for retail purchases of medicines, but is it a community care pharmacy?
It is a community care pharmacy, but when I say retail pharmacy, and I did see Jason Fournier is on the call, if there's specific questions, community care can fill prescriptions for anybody in the community. Right.
No, that's right, and I would assume that that's money for us. So I'm supportive of that idea. Anyway, I just wanted clarification on that.
Yes.
Are there going to be evening hours?
We are working on that specific question. Community care as the clinical operator and the clinical side will have to determine what the clinical hours are. For the wellness component, though, we obviously know that there are other services and programs that need to be available, and we are absolutely taking that into account. Elizabeth Marrero is leading that effort for these two sites, and understanding, more about what the community needs and how they would like to use these sites. It's all something that we hope to get more input on over the course of this next year. And I think, Hornsby Bend, we really do see as having that community wellness component, and we'll want to work with the community and making sure that it is available, those services are available.
I appreciate that, and I like the way you keep using the word community, but first and foremost in my mind is whether or not the hours are going to be what our patients need. And I'd like to know, I just want to make sure that they're differentiating between the two. I want to have use of a community room so I can have a meeting. that not just me wanting to have a meeting there for my organization doesn't necessarily mean that that's the best time for MAP patients. But I do want to make sure that we're checking with the patients or of that population of that area to make sure that we're serving their needs first. And then anything extra is fine. You know, you said, the reason I'm saying that is because you said that there are already community groups that want to have access to those little rooms. Well, I think that should be dealt with by those individuals within those that reside in those areas that will be using those facilities. Okay, and also I think I understood you to say that we were going to be having childcare there also in both sites.
No, we don't have childcare directly. And actually what I was referring to is we've been approached by WIC to have an office there.
Okay.
So it's a little bit different.
Well, no, WIC serves our population, so that is a need.
Absolutely.
That's a great need for our low-income population.
So we do not have childcare on site. The Dell Valley site is wholly dedicated to health clinical services with a very small portion in the front for community resources. We will have I think community care intends to have a very robust pediatric presence there, including pediatric dental, as well as primary care, healthcare. There will be features there that will allow, families to come together and, activities, for example, play features, et cetera, that will accommodate, we hope, families coming together at the site. We do not have a childcare provider though.
Okay, what I was referring, what I'm specifically wanting to have addressed is the ability for kids to be there while the mother or the patient is being seen, and they may not necessarily be allowed, or it won't be appropriate for them to be in the exam room. That's what I'm referring to.
Yes, we will. We are taking that into account. Absolutely.
Thank you very much.
Thank you, Stephanie. Congratulations to you and your team. It just looks very exciting, and we really appreciate the constant updates. I think that's a wonderful thing. So we'd like to continue to have those. But does anyone else have any questions?
Madam
Yes.
Chair, I just want to make a quick comment. One, I'd like to congratulate Stephanie and her team on the great work they've done and the long ways that they've come in terms of getting us to this point. That's been a real challenge, but they've done a great job, and I appreciate that very much. The second thing, though, I do want to highlight, sort of piggyback off of what Manager Valadez says somewhat, is that because these facilities will come online at different times, but relatively close in terms of where we've come from, I think it's important that our outreach to the community, so that they will understand what the two facilities will be providing, because I could envision perhaps somewhere down the road a question of equity between the two communities. And so I think it's important that we, as we roll out Hornsby Bean and then Dell Valley, that we engage, as Ted and his team has done, what's Hornsby is, why it's there, what services will be there, why those services are there. And the same thing in Dell Valley, so that once this Dell Valley one comes on with a few more amenities than Hornsby Bean, we don't get in the situation of why them and not us. And those are political realities that will happen. And I just want to give us a heads up to try and anticipate that. Particularly the pharmacy comes to mind, but as well as some other services as well.
Absolutely. And we're very mindful of that. I think that's part of the reason why we are really working to engage at the community level while we are trying to determine some of these amenities and the programming and the partnerships, because we do see that there are different needs in these communities as well.
Sure, Madam.
Yes, Mr. Giesman.
Yes, and thank you, Madam Chair. To add to what Stephanie had provided, it's also important to understand that what starts out in each of these health and wellness centers may be different in a year, and in 2 years, and in 5 years. And it's as we get into the next agenda items in this committee meeting, in terms of the sophistication of the planning and coordination with our partners at Community Care. you know, we're always looking to address health in the community. That's the starting point. And the health equity in the community, that's the starting point. So, again, we'll certainly, absolutely, there's a lot of community engagement that's built into this process for the very reason, Manager Jones, that you pointed out. But we'll continue to make sure that we're connected to the communities in terms of what those service offerings, you know, how they grow or change over time. Absolutely. Thank you.
Yes, Madam Mustafi.
Oh, thank you so much for the presentation and for the work that you have done. I'm really excited to see the progress that you have made. It's incredible, and I look forward for our grand opening. Now, the most important thing is building these buildings, and I assume once we have these buildings in place, we'll be able to add additional services like child care, as long as we have the room. And a lot of facilities do contract with other facilities to offer this important service for moms. Now, in terms of pharmacies, what I've noticed with some institutions, they're moving away from the brick and mortar, and they're providing, you know, pharmacy, they're actually delivering at home and more personalized care. For instance, I get all my medication delivered straight to my home. I have not been going to the pharmacy to get my regular medication if needed. So that's something that we should probably think about, something more personalized, given the barriers our community may face in terms of cost and transportation that we can definitely explore. Thanks again, Stephanie, to you and your team, and to our community as well.
Lovely, yes, thank you. And does anyone else have any comments or questions?
Madam Chair, if I might, I just would like to add that we did execute the second of 3 agreements required to advance our Colony Park Health and Wellness Center. More to come there. We have an October 11th of this year closing date on that property, but we did execute the infrastructure agreement. And that's mostly because Mike Giesland set some ambitious goals that we actually met and the city met.
That's fantastic. Thank you. So that's very uplifting, all of this. So thank you so much for your time and effort.
Madam Chair?
Yes?
This is Cynthia Valadez. I apologize again. I think I just have a technical question. How do I mute myself? I know how to unmute myself on the phone, but how do I mute myself?
Manager Valdez, you press star and 6. And that
Okay, for both.
And it will unmute you.
Thank you. Thank you, bye.
Absolutely.
So, members, so after this wonderful presentation, we will now return to our regular agenda for the Strategic Planning Committee with item number 1. Item number 1, we will receive a presentation from Guidehouse, Inc. on the proposed equity-focused service delivery strategic plan. Monica Crowley and the Guidehouse team, including Dr. Abhi Sharma and Danielle Srinivasan, will be presenting. Before we start, though, I'd like to comment that if you have questions, we would prefer, if it's on this direct slide deck, to go ahead and ask your question. But if not, we would like to keep this presentation very focused on the presentation itself. Any questions over the whole system of care planning, et cetera, please write them down and send them in to the staff, because next week we have our whole meeting on question and answers for all of the questions over this whole plan. Thank you so much. And yes, so Monica, are you all ready?
Yes, thank you, Chair Brunson. Monica Crowley, Central Health. I'm really excited about bringing this presentation to you today. This presentation of the proposed equity-focused service delivery strategic plan represents the culmination of over a year's work on Central Health staff and the board's part, and 6 months of work with Guidehouse and many board and community discussions in support of the development of this proposed equity focused service delivery strategic plan to help us build a comprehensive high-functioning system of care. In the past few weeks, you have received presentations that have gone over the results of our Voice of the Community engagement assessment, the Safety Net Community Health Needs Assessment, which we have never done a safety net focused solely under 200% of the federal poverty level community health needs assessment, even though we continue to participate in the overall CHNA with Austin Public Health. This is our first safety net community health needs assessment and our first safety net focused clinical capabilities and gap analysis assessment. Today, all of that work is coming together in this presentation on the proposed service delivery strategic plan and the proposed goal and imperatives. And now I'm going to hand it off to Dr. Sharma and Danielle. Thank you all so much.
Thanks, Monica. So like Monica mentioned, what we are going to share with you today is a culmination of an year worth of work. And again, what we want to highlight today is the path forward. So strategy by nature is forward-looking, and we want to spend time going through some key highlights from our strategic plan. Now, if you go to the next slide, it has a list of things that we want to cover today. We will start off by providing background and summary of engagement objectives. The second section that we would go to would be the strategic planning. So how did we identify what went into the strategic plan, and why is something that is in the strategic plan there? So the why behind the strategic plan will be answered through item number 2. Item number 3 is the strategic plan itself. So we will walk through the inclusions of the strategic plan, some of the ideas around sequencing and prioritization, and how we would measure whether we are tracking towards the goals that we have set for ourselves. And then we will leave some time at the end for questions and next steps. Again, I want to highlight the fact that this content would be forward-looking. So we will start off by talking about what we found out through our current state assessment, and then we dive into how that informs where we go next. And with that, I'll pass it to Danielle.
Thanks, Abby. If we can move to the next slide, please. Slide 3. Thank you. So on slide 3, what we want to do is just revisit Central Health's 2019 through 2024 strategic plan objectives. These objectives are so important because they served as the foundation to drive all of the work that's been completed over the past year. So just keeping in mind that number 1, developing and executing healthcare delivery strategy based on people in place. So the findings from the CHNA really helped us to achieve this objective as we were really thoughtful in developing the equity-focused service delivery strategic plan. Number 2, implementing patient-focused and coordinated healthcare system. So really understanding from an epidemiological standpoint, what are some of those key drivers that were going to be effective to serve the safety net community in Travis County. So considering age, gender, demographics, social determinants of health, health outcomes, et cetera. Those were all driving factors to help us develop a strategy that will really help us build a high functioning, equity focused system of care. And number 3, implement a sustainable financial model for healthcare delivery strategies through fiscal year 2024. So what we're doing through this work is really understanding the investment and capital that will be required to drive success. Next slide, please. Slide 4 is a slide that we've presented to you now for 3 weeks in a row, but really just want to recap on the journey that we've been on together and the information that we've shared with you to get to this point today. So 2 weeks ago from today, we shared with you our findings from the Voice of the Community work, which really helped us develop a holistic community engagement strategy to understand the perspectives of patients, providers, and community members to really ensure that we're reaching those hard to reach patients as we think about addressing the healthcare needs of the safety net community in Travis County. Number 2 was the Community Health Needs Assessment, which we presented to you last week. And through that work, we were able to understand the current state of the safety net healthcare system in Travis County, including gaps in future needs based on the health outcomes of the patients that we serve today and those that we can expand our reach to in the future. Number 3 is the equity-focused service delivery strategic plan, which is what we are presenting to you today. This is a culmination of all of the work that's been presented and represents the strategies and goals that will position Central Health to build a comprehensive, high-functioning healthcare delivery system that will improve the health of our patients. Next slide, please. Next slide, please. So the next few slides represent just some key strategic planning concepts that we'd like to introduce to you as we start to talk about the future goals and strategies.
I apologize. When you are saying next slide, next slide, next slide, I don't have a computer, so I can't see the slides. If you could please say the top. Is it recap, engagement objectives, strategic planning, principles of supply, availability, and demand? You know, just let me, if you can just say that, I'd appreciate it.
Absolutely. We're on slide 6, Manager Valdez.
Okay, slide 6 begins with what?
It says strategic planning, principles of supply, availability, and demand.
That's it. I'm on the right, thank you, I'm on the right page.
Sure thing. So on this slide, what we've done is just outline the key concepts of supply, which is availability today, and then demand, which represents future need. And what this really does is it helps us forecast the needs across Travis County's safety net patients and design strategies that will address this community's healthcare needs and improve their overall health. So when we think about demand, it's the service needs that are typically dependent on population, demographics, epidemiology, location, access, and availability. So really drilling down and answering the questions of what are the services that are needed, how urgently are they needed, so timely access, and how often are those services needed. Lastly, answering the question, where should the services be offered? So when we consider some of the local neighborhood level needs that we visited last week, where should we place those services so that we're meeting the needs of the community? When we think about access, again, where should the services be offered? What type of investment, so capital, is required to execute on that access? And who should provide these services? So really answering the questions on supply related to clinical needs, how do we engage with our members and patients, and those that we don't serve, including those hard to reach patients that would be eligible for our care. What are the patient experience needs? And then the resources required to provide these services. Next slide, please. So how does the equity-focused service delivery strategic plan guide our operations and financial planning. So on slide 7, what we've done is outlined and described how the equity-focused service delivery strategic plan will influence and drive our operational and financial planning efforts. So the equity-focused service delivery strategic plan represents a time period of 3 to 7 years out. It's based on evolving care models, gap analyses, the voice of the community work, and forecasts that really inform what the future healthcare needs of Central Health's patients and those that are eligible for our care represent. When we think about the operational and implementation plans, that's a 1 to 3 year period. We know that in healthcare, we often have to be flexible and adapt to change. These operating models represent the immediate and future actions that are needed to execute on some of these strategies. The financial sustainability plan represents a long-range strategic financial plan that includes an operating budget, a capital budget and plan, including considerations for future master facility planning. Next slide, please. I'm going to now transition this to Dr. Sharma.
Thanks, Danielle. So as we think about the future, I think it's very important for us to keep an eye on what's going on in the Austin market in particular, but also what's going on in Texas and what's going on at the national level. So the slide here talks about the immediacy and scale of regional needs and how an understanding of these needs serves as a foundation for us to stay abreast with industry changes so that our strategic plan is meeting the needs of the community. So we analyzed the market and we identified 6 key trends that we need to be aware of. So if you start at 12 o'clock, the first thing that we need to be aware of is the shortage of physician supply. And I would go on to say that it's not just physician supply, it's supply of clinicians. There is a nursing shortage. So we need to be careful about how we can navigate scarcity of physicians as well as of support staff to make sure that we are developing the infrastructure that is allowing us to meet the needs of the community. Number 2 is increasing demand. Now, COVID-19 has exacerbated a lot of clinical conditions, more so conditions related to behavioral health than non-behavioral health related conditions. So as we think about the waxing and waning of COVID-19, what we are seeing in clinics is that a lot of patients who had delayed care because they didn't want to go to hospitals are suddenly appearing in the ED or at primary care clinics with an acute form of illness that would not have been the state if they would have been to a clinic in a timely manner. And this is going to continue. So as we move forward, the demand for services is going to increase. Number 3 are policy changes, and policy changes specifically around telehealth and behavioral health. So we know that the federal government is putting a lot of money into supporting telehealth related programs. And the federal government is also putting a lot of money in helping states and counties create behavioral health programs that are targeted and are aimed at patients who have all of a sudden come to a state where the behavioral health needs have surpassed the point where they can be seen with the current supply in the system. So as we look to the future, our ability to use telehealth as a key determinant of how we meet demand and how we can leverage funding to build telehealth and behavioral health related capacity is going to be a key determinant of our success. Number 4 is population. So we know that within Travis County, the population is growing rapidly. And what's more important for us is that the low-income population is expected to grow annually over the next 5 years. And the school of thoughts are out, but some say that the rate of increase in low-income population is going to be higher than that of the general population. But again, as we think about the demand of services, the volume of that demand is going to increase because the population that we are serving is going to increase. Number 5 is consumerism. So patients are playing a more active role in clinical decision-making, and they have choices to select a provider. Now, we understand that the patients that we are responsible for do not have a lot of choice, but when we think about the systems of care and the competitive landscape in Austin, just being aware of the consumer-centric nature of care is going to be important because our partners are going to change their strategy based on what high-paying patients need, and that has to be a key consideration for us. And number 6 is a concentrated provider market. So we've done these studies in a lot of markets, and Austin is unique because in Austin, 2 systems are dominant. If you think about inpatient discharges, 85% of discharges are coming out of 2 systems. Now that's good and bad. That's good because it allows us to selectively use those systems to deliver inpatient care to our patients, but then it also poses a risk of over-reliance. And when we think about the future, the fact that this market is highly concentrated is going to be a key driver of what our strategy should be and how our tactics to support those strategies get executed. Next slide, please. Now we know that the market is changing, there is need, and the supply of physicians is going to be a key limiting factor for what we can do. But what we can do is, again, dependent on how we leverage our capabilities and the capabilities of our partners to create a high-functioning safety net provider system. We've shared this slide a couple of times before as well, but this slide talks about how complex a safety net system is. And then if you think about the different components that make up a safety net system, to overgeneralize it, there are 2 broad sets of components that fit together for the system to work. The first one are services that are clinical in nature. Now, the blue cogs that you see on the periphery of the purple central cog are those clinically based service areas. So think about population health, primary care, post-acute, hospital care, and specialty care. All of those services are where the rubber meets the road. Right at the center, you have navigation services. Now, these services are more important for a safety net system than they are for a commercial provider, because in a safety net system, continuity of care and the coordination of care between points of care is a key driver of quality and of better clinical outcomes. So when we think about what we need to do in the future, we need to make sure that we are not only hitting on how and where these services are delivered, but also how this cog in the center is constituted and how this makes the other cogs go by providing coordination of care and navigation-related services to our patients. Next slide, please. And Danielle, I'll pass it to you here.
Great. Thank you, Dr. Sharma. So on slide 10, what we've shown to you is a slide that we presented last week, but really just want to reinforce how all of our strategies and analyses were formulated. And when we look at Travis County and its broad geographic reach and population size, we were able to divide Travis County into 14 planning and assessment regions. And this was accomplished through a very thoughtful approach in collaboration with Central Health's leadership team that included really assessing geographic borders, level of urbanization, transportation resources, and population density. And really core to all of this was to really understand what the local healthcare needs of Travis County's low-income populations were at that neighborhood level. Next slide, please. On slide 11, what we've provided you is also an analysis that we've presented to you in the past that represents Central Health's current enrollment across each of these 14 planning and assessment regions. What's striking is that when we look at your current enrollment, Runberg represents one of the largest, if not the largest, areas of enrolled populations. It also represents one of the areas with the greatest opportunity to expand our reach and enroll additional residents that will be eligible for Central Health services. Broadly, Central Health's current enrollment is highest along the I-35 corridor. Further opportunities exist to really expand our reach across the I-35 corridor, East Travis County and West Travis County, nearly doubling our current enrollment size. Next slide, please. On slide 12, this is a there are two maps on this slide that illustrate Travis County's residents with incomes below 200% of the federal poverty level. And what we've done is this was actually presented to you last week as well, but wanted to remind you as we work through some of the strategies and goals that will be presented later today, that 74% of Travis County's residents that are low income reside in that I-35 corridor. So the map on the left represents the absolute population, so based on numbers alone, and then the map on the right represents population density per square mile. Next slide, please. On slide 13, this represents a summary of the scale and scope of clinical needs that are forecasted to increase across Travis County's safety net community across the future. This slide was also presented to you last week and is a recap of our discussion. But as you can see on this slide, we've evaluated the clinical needs across 8 key categories: primary care, wellness and prevention, urgent and convenient care, specialty care, behavioral health, dental, hospital, and post-acute services. And as you can see on this slide, and as previously presented to you, the most acute needs or significant gaps exist in specialty care, dental, hospital, and post-acute. Subsequently, moderate needs exist across primary care, wellness and prevention, urgent and convenient care, and behavioral health. Next slide, please. On slide 14, we've summarized for you the primary and specialty care physician needs analysis that we presented to you last week that is very specific and represents the number of providers that are needed to support Central Health's enrolled patient population. So the column along the middle represents existing FTEs or physician or advanced providers that are dedicated to serving central health patients today. The columns along the far right represent the provider needs to serve the central health enrolled patient population. And as you will see, there are gaps across almost all specialties. Next slide, please. And now I'm going to hand it off to Dr. Sharma.
Thanks, Danielle. So by now, what we have shown is, number one, there are significant needs across a lot of key specialty areas as well as primary care that need to be met. We've also shown that the current physician complement is not enough to meet those needs. Now, what this slide talks about is how does the profile of our partner and contractor portfolio enable us to meet those needs? Now, this slide here specifically talks about each of the provider systems that we have partnerships with along two variables. So the first one, which you see on the vertical axis, is how many of our patients are actually seeking care at these sites or systems. And if you look at the horizontal axis, it talks about, okay, so for each of these systems, what kind of services are our patients seeking and how broad is that set? Now, what will stick out to you here is that community care and Ascension are on the top right corner. What that means is they are seeing a lot of our patients, and then they are delivering a lot of different services to our patients. But if you look at the cluster of partners and safety net providers that are outside of the top right quadrant, you see that all of these systems are providing care to our patients, but depending on the system that we are talking about, the array of services at some of these systems or partner providers is extremely small. Now, what this says is that we are over-reliant on community care and Ascension to meet a lot of our needs. And the good thing there is that these two systems provide a lot of services, and it is obvious that patients are seeking care there. Now, the question that this poses is, what is the value that these other systems are driving? Now, these systems are driving value to us because our patients are still going there. If we think about the future, we need to think about how we can make sure that we are gradually reducing our reliance on the big systems, and then we are optimizing what we are doing with the smaller systems to make sure that when Ascension closes its door to our patients because they don't have capacity, there are other places for us to send our patients. Now, again, as we think about the future, thinking about the partner portfolio and the service complement that is provided through the constellation of our partners is going to be a key thing that we need to input into our strategic decisions. Next slide, please. Now, we talked about the clinical aspect of meeting the needs of our community. Now, what we did on this slide was we assessed the capabilities of central health along 5 key dimensions. And we chose these 5 dimensions because from our work with other systems across the country and specifically here in Texas, these are the 5 areas that safety net systems need to be extremely strong at in order to meet the needs of the community, but also to keep themselves evolving to meet the ever-changing needs of the community that they're serving. So what we found out was, if you look at the chart here, the way to read each of these domains is to look at the green circle first. That is where central health capabilities are, and then look at the blue circle next. That is where some of the high performing safety net systems are along those capabilities. Now, I want to make sure that I highlight a couple of things that are important for us to understand before we start looking at each of these domains. The systems that we assessed central health against are different in some key aspects. So I'll use the example of Harris Health. So Harris Health is one of the systems that was used to think about where the blue circles are. Now, Harris Health is an old system. It was started in the 60s. We are relatively young. So they've had a longer runway to build their capabilities. Number two, Harris Health is extremely focused on who they take care of. They take care of individuals who are below 150% of the federal poverty limit. We take care of a broader set of individuals. Number three, they're extremely focused on what they do. They are not trying to be everything for everybody. And I'm not saying that we are, but when we think about the services that we are focused on, the services that Central Health is focused on are broader than what Harris Health focuses on right now. So it's not a surprise that the blue rings are to the right, but there are these core differences which need to be understood before we think about evaluating these two sets of data. The first thing that we looked at was access and capacity. We know that we have broad geographic coverage across Travis County, but despite having that broad coverage, we are still not meeting the needs of our patients, primarily because some of the geographic regions within Travis County are extremely deficient in physical facilities. Behavioral health is a classic example. We don't have behavioral health facilities that are spread across evenly for us to meet the needs of our patients. The second thing is data and analytics. Now, this is important because, as I mentioned, for the safety net population to get care across the continuum of care, care coordination needs to be managed efficiently. And the backbone of care coordination is active and timely sharing of data. Now, the second thing that makes data and analytics important is because if you're strapped with resources, you need to make sure that you are using your resources appropriately. A lot of systems are using data to run risk stratification models, which then allow them to put patients in different risk categories. And the group that has the highest risk is tagged to the most intense form of care coordination, which is driven by more individuals in the care team than individuals who are at the lower risk level. So if you think about data and analytics, yes, we know that we have the foundational infrastructure to run analytics, to capture data, but the lack of getting data from our systems is a key limiting factor that allows us to move to the right on this scale. The third thing is system of care. So if you think about system of care, I always think about it as making sure that we have the physician supply and the service complement to actually meet the clinical needs of our patients. When we think about central health, we know that we are dependent on two big systems, but if we think about what that does to us, it poses a challenge because of how being reliant on those two systems, wait times for services that are exclusively provided by those two systems are extremely high. And a key factor that we need to consider here is how our contracts are made enforceable. And we need to make sure that if we think about contracting in the future, that our contracts are enforceable and they allow for our partner systems to use their capabilities to actually meet the needs of our patients. Number four is care coordination. So care coordination is based on availability of data. It's based on right incentives, and it's also based on shared communication platforms. Now, limited sharing of data between provider systems, and lack of a centralized communication platform is posing challenges to how we do care coordination. Number 5 is member engagement. So for member engagement, we know that a lot has been done in the past, and what we've done in the recent past has delivered results, but there is room for improvement. We need to make sure that we train our clinical staff to deliver culturally competent care. And we also need to make sure that we use data to target specific groups in a way that is feasible for them to understand and also engages them to become active participants in decisions around healthcare. So all in all, the foundational infrastructure for us to build off of exists. What we do with it is going to be a key determinant of how successful we are as we think about moving to the future. Next slide, please. So in this last section, we'll go through the equity-focused service delivery strategic plan. And the one thing that I want to say here is, we know that Central Health has a broader strategic plan that would guide strategic priorities from 2019 through to 2024. What we are going to cover today is the component of that plan, which is based on how we improve service delivery. So again, we are not going in and deconstructing the strategic plan that was already created. This is, again, focused on how we meet community needs, and will focus on equity-focused service delivery. If you go to the next slide. So when we think about strategy, as I mentioned, it is forward-looking. Now, if you look at this slide, it essentially talks about a step-ladder approach to how we go from where we are to becoming a functional, integrated system. Now, the key thing that I want to highlight here is these steps are not sequential. These steps can happen concurrently. But if we think about how we can go from where we are to becoming fully integrated in a step-by-step manner, the first thing that we need to do is we need to define our future vision, which is based on identifying what our mission is and then using that to devise a strategic plan. That is where we are. What we will share with you is the strategic plan. The second thing that needs to be done is establishing a governance model and then setting up accountability standards. We know that we've had challenges enforcing accountability with our partner systems. So we need to make sure that we create a governance model that is inclusive, realistic, and enforceable. The third thing that we need to do is think about funding and operations. So like Danielle mentioned on a previous slide, we need to think about how financial sustainability and operational implementation are driven through what goes in the strategic plan. We have to be extremely focused around how we are using funds and how we are evolving our capabilities to refine operations so that we can continually evolve. So once we are at a point where we check boxes 1, 2, and 3, the next step is clinical excellence. So this goes to the idea of enhancing clinical quality. And if you think about clinical quality, we need to make sure that all of our strategies are bolstering quality of care for our patients. The last step on this road is functional integration. So we know that we have anchored ourselves to the idea of a system of care. Now, the word system in itself means integrating disparate parts that come together to solve a function. So as we think about functional integration, we need to make sure that we are leveraging our capabilities to the most. And we are also leveraging our partners to allow them to do what they do best. So when we think about the system of care, we need to be extremely careful about what we own, what we manage, and what we contract or partner for. Eventually, how quickly and how efficiently we move to the future will be dependent on the key decisions around, again, what we own, what we manage, and what we contract for. Next slide, please. So when we think about the strategic goals and imperatives, the best way to think about it is it's like the facade of a house. You have the roof and then you have the pillars. So the roof is the strategic goal. So the text that is highlighted in the green box is the strategic goal of our equity-focused service delivery strategic plan. Now, the pillars are the strategic imperatives. So we have 4 strategic imperatives, and the roof and the pillar need to be set up so that they are supporting the system that is delivering care to our patients. So the strategic goal is to develop an equitable system of care that is comprehensive, so provides a broad swath of services and accountable, while optimizing the collective use of capability and resources to serve the safety net population. The 2 things that I want to highlight here are number 1, accountable, and number 2 is collective use of capabilities and resources. Again, I want us to think about the system of care and how we need to think about building the future by executing on the idea of an integrated, accountable system that uses its capabilities collectively to meet the needs of our population. The 4 strategic imperatives that would allow us to reach this goal are number 1, access and capacity. Number 2, care coordination. Number 3, member enrollment and engagement. And number 4, system of care infrastructure. We go into the details of each of these in subsequent slides. So I'll just move to the next slide and take these on one by one. So we talked about the goals and the strategic imperatives, but we also need to think about the critical elements that would allow us or deter us from reaching our goals. So we know that the 4 imperatives or focus areas that we want to work on are access and capacity, care coordination, member engagement, system of care. But when we think about the elements that are required for us to execute on these imperatives, the thing that we need to focus on first and foremost, and this is an equivocal truth, is clinical staff. We are short on staff. We need to make sure that we have a strategy on how we meet staffing shortages. Number 2 is administrative staff. We want our clinical staff to work at the top of their license and spend a lot of their time actually taking care of patients. And for that, having support staff, administrative staff is a key. Number 3 is IT and systems. So a lot of things that we want to do are dependent on having efficient IT systems and platforms. Think about care coordination, member engagement, risk stratification, allowing clinicians to operate at the top of their license. All of these are enabled by IT capabilities, so that has to be a key element for us to think about. Number 4 is data management capabilities. So when we think about data management capabilities, it starts from enforcing terms that allow partners to share data in a timely manner, and then the subsequent process of how we manage that data and how we take that data to actually inform decision making. So the end-to-end data management life cycle needs to be looked at and bolstered by developing these capabilities. The next one is contracts and agreements. The 2x2 slide with the partners and the safety net providers shows that we have a lot of contracts and agreements. So a key aspect for us to delve into is how these contracts are allowing us to meet the needs of our patients, but also how these contracts are made enforceable so that the partners who we have contracts with are actually living up to the terms and giving us what they have signed up for. Number 6 is fiscal capacity. So things 1, 2, 3, 4 require a lot of funding. So when we think about how we execute on our imperatives, thinking about what our fiscal capacity is and how we can optimize the use of our fiscal capacity to use these elements or levers to then meet the needs of our community by focusing on these imperatives is going to be a key step as we think about future planning. Next slide, please. So in the next 5 or 6 slides, we'll go through each of the 4 imperatives that we want to focus on in our strategic plan. Now, the first imperative that we want to focus on is access and capacity. So let me take a step back and just acquaint you with the way the slide is structured. So we know that we have 4 imperatives. On each of these slides, we have identified strategic priorities for us, which is the what we need to do. We've also identified execution tactics, which is the how of, it's the how of the what, so how are we going to get the what done. We've also identified some measures of progress. So as we think about the future, we need to set accountability standards for ourselves as well as for our partners. So how can we make sure that we are tracking progress in the right way? And we've also identified notable headwinds. So when we think about execution, what are some of the key considerations that need to be kept in mind when we think about prioritizing and using our funds appropriately? So this slide here talks about access and capacity. So for access and capacity, we've created 3 different slides. The first one will focus on primary care. The second one will focus on specialty care, and the last one will focus on inpatient and acute care. So this slide here talks about primary care. Now, our strategic priorities for primary care are number 1, to expand access for existing patients, high priority efforts concentrated in areas of greatest need. Number 2 is offering same-day appointments for patients with acute needs. The execution tactics, or the how we will get this done, are number 1, creating and expanding access points, specifically in East Travis County. And we are not saying that we are ignoring other parts, but if you think about the tactics that would get us to where we want to be quickly, this is number 1. Number 2 is increasing capacity for same-day appointments and extended hours capacity. Number 3 is closing current physician gaps and ensuring that we have an adequate supply of physicians that actually meets the needs and leverages existing capacity. And number 4 is enhancements and improvements to technology. Again, we're using technology as an enabler to make the system more efficient so that we can do more with less. The key measures of progress here are number 1, reduction in wait times for primary care. Number 2, decrease in third available appointment wait times. Number 3 is increase in clinical and physical primary care capacity. So hiring more physicians where physicians are needed and adding more sites where sites are needed. The 4th measure of progress here is increase in the percentage of patients receiving recommended preventative care screenings. Number 5 is increase in number of same-day appointments. And number 6 is decrease in utilization of emergency care. Now, we know that a lot of our patients go to the emergency care setting as a first resort. By opening up adequate primary care capacity, we should see a decrease in utilization in ED care, and that's the logic behind measure number 6 here. As we think about how we execute on these, there are some notable headwinds that we need to be careful of. The first one is physician supply is extremely scant and is going to decrease into the future. Number 2, if you think about physician recruitment, we are competing with big systems for the same specialties, and physician recruitment within the Austin area is going to be a challenge. The third one is the geographic expanse and distribution of primary care needs to be related to where populations are located so that we are meeting the needs of patients. The fourth one is we are forecasting a increase in enrollment. And if we think about the supply, demand scale, demand is going to increase, which will put more pressure on existing capacity and would also require more capacity to be built. And the last one here is priorities for other provider entities. Like I mentioned, the specialties that we are deficient in are the specialties that the big systems are seeking providers for. So there's going to be a tug of war, and recruitment and priorities that are at loggerheads with each other are going to pose challenges as we think about meeting primary care needs. Next slide, please. So this slide talks about specialty care. We have, again, 2 strategic priorities here. The first one is to create access to specialties with significant unmet needs. Through our physician analyses, we have identified areas where the physician FTE count is like 0.02. And if you put the productivity of a physician on top of that, it translates to 2 or 3 appointments in a week. So we need to make sure that we are creating access specifically for areas of unmet need. Number 2 is optimizing the use of existing specialty service capacity through contractual and operational initiatives. So the execution tactics here, number 1, developing strategically located multi-specialty facilities. Now, the difference between a multi-specialty facility and opening up 5 specialty clinics in different locations is that if you have a multi-specialty facility, coordinating care between providers is easier. And if a patient comes to this facility, 2 or 3 of their needs across different specialties can be met in the same day versus sending them out to a facility that is away where we again risk losing the patient. Number 2 is expanding ambulatory, diagnostic, and therapeutic capabilities. Number 3 is developing capacity and optimizing the use of ASCs. And ASCs, again, ambulatory surgical centers. A lot of inpatient surgeries are being moved to an outpatient setting for billing reasons, for accessibility reasons. So we need to make sure that we are building capacity where we can deliver these surgeries and procedures, but we are also optimizing current capacity wherever it exists. Number 4 is designing specialty care programs that are tailored to address the disease burden impacting our patients. So think about disease management programs specific for diabetes, specific for metabolic syndrome. We need to make sure that our programs are meeting the unique needs of our population. And in order to do that, they have to be based on the clinical and epidemiological profile of our population. Number 5 is closing physician and provider gaps based on needs assessment results. So if you try to think about the slide that had the physician count on it, we see a lot of deficiencies across the board. So when we think about the future, we need to make sure that we are closing gaps, and we need to then prioritize gaps based on the impact of closing those gaps and the level of effort that goes into closing the gaps that we've identified. The last tactic here is enhancements and improvements to technology, again, using technology as an enabler. The measures of progress here are number one, reduction in wait times for specialty appointments, increase in clinical and physical capacity, specifically for specialty care appointment, as well as for surgeries and procedures through ASCs. Number three is increase in available capacity for existing providers. We want to make sure that we optimize existing capacity so that we move the needle quickly. Some of the notable headwinds that we need to be aware of are number one, we are again over-reliant on some of our partners. Number two, there is a limited supply of specialty physicians, which, similar to primary care physicians, is going to drive recruitment issues. Three, for surgical subspecialties and specialties in particular, the gap is immense. And what we need to do here is think extremely strategically about whether we own, manage, or contract for these services, and for which services do we need to take which path. Number four is priorities of other provider entities. Again, every provider system is fighting for physicians for the same specialties, and that poses huge risks to our ability to recruit physicians for the specialties that we need most. Next slide, please. So this slide talks about inpatient and acute care. So our strategic priorities here are number one, ensuring appropriate and timely access to acute and post-acute services, which are supported by effective transitions in care. We've seen that post-discharge, a lot of our patients just fall through the cracks. So we want to make sure that not only are we providing these services, but we are also creating the safety net that allows them to move from an inpatient setting to a primary care physician or a specialty care physician. Number two is shift services from hospital settings to ASCs or other outpatient locations as appropriate. Number three is create access to post-acute services with significant unmet needs. And skilled nursing and respite are two of those significant unmet needs that we need to coalesce around to meet, to fill the gaps that exist here. Execution tactics, number one, expanding access points to shift care from hospital to a more appropriate sites. Procedures are a classic example of that. A lot of procedures are being done in an outpatient setting. We want to make sure that our patients get the same quality of care and also get an opportunity to access care in a timely manner. And the shift from hospital to outpatient is going to affect that. Number two, expanding access to same-day and post-discharge follow-up appointments. Number three, designing specialty care programs that are tailored to address the disease burden in collaboration with our hospital partners. Again, think about disease management programs for specific diseases. Think about case management programs for individuals who are turning up to the EDs frequently. All of these things need to be thought of as ways for us to close current gaps. And the last one here is obtaining accurate, timely, and actionable hospital data. So the measures of progress that we will track our progress against are, number one, reduction in readmissions. Number two, reduction in level 1 and 2 ED visits. Number three, diagnosis-specific length of stay that is within median ranges and is adjusted using the case mix or other acuity indices. And number four is increase in proportion of overall spend in non-hospital settings. As we look to the future, some of the notable headwinds here are number one, COVID-19 related resource scarcity and overutilization of inpatient capacity. Number two is Austin being a highly concentrated market where two systems are attributed with 85% of inpatient discharges. It is an extremely competitive environment, so we need to be aware of that as we think about how we close these gaps. Number three is post-acute care provider supply in the market is limited, and we need to make sure that we think about how we will meet this demand, given the fact that demand is high and supply is low. And number 4 is limited care coordination capabilities. So if you think about the connection between acute care and primary care or specialty care, a lot of our patients fall through. A core foundational element that will allow us to move patients smoothly through the continuum of care is the development of a care coordination model, which is based on, again, leveraging IT-related capabilities to ensure that patients are moving through the system in a timely and effective manner. And Danielle, I'll pass it to you for the next slide. Next slide, please.
Thank you. Okay. Slide 24 really relates to care transitions and care coordination. So what we've done here is define 3 overarching strategic priorities to achieve effective transitions in care for our patients across the care continuum. So number 1, develop a standardized care coordination model for the system of care. So setting guardrails and consistency. Number 2, improve the timeliness and effectiveness of patient transitions between providers and points of care. So really looking at how can we make this system more efficient as patients move across providers and care settings, so that multidisciplinary approach across the continuum. Number 3 is proactive, timely, and relevant communication between care teams and providers that are involved in treating a single patient. So really making sure that we're really supporting that multidisciplinary approach to care treatment and planning, and having effective communication across care teams so that we can really make an impact on health and wellness for that given patient. So how are we going to do this? What are the actions that we need to execute on to achieve these priorities? So number 1 are the risk stratification processes and solutions. Number 2, further developing our processes and solutions to enable timely data sharing using our health record, and then also medical documentation. Number 3, centralizing communication platforms to enable and enhance provider communication, so that provider to provider communication. Number 4, training our care coordination workforce so that they are well versed in what that standard model of care looks like and what are the standards that we're trying to achieve. Number 5 is aligning the system, provider organization, and care team incentives to enhance our care coordination processes. So how will we measure our progress or success? What we've done is we've defined 8 key measures to measure our performance and help us identify how we're tracking towards achieving these priorities. Number 1 is the number of providers and systems that have data sharing agreements in place that include enforceable, near real-time data for patients' medical documentation. So our access to that medical information. And that's so important because often at times, as we're looking to treat patients that present with acute problems, having that information will really help us understand recent history so that we can formulate the best intervention strategies to improve their health and wellness. Number 2, the number of patients with an annual care plan. Number 3, the percentage of patients no-shows for follow-up appointments. So how are we managing care and that follow-up so that we can avoid unnecessary ED visits, hospital readmissions, and assure that patients are following their care plans and that their care is being coordinated effectively. Number 4, the number of warm handoffs for transitions in care. Number 5 is the number of instances where patients' medical documentation was shared per 1,000 transitions. So what that does is it helps us understand on a normalized basis how we're doing in terms of sharing patient information that's critical to effective care management. Number 6, the number of patients with discharge plans. So are we providing them with their discharge information through a plan where the patient is engaged as well as their care teams? So is everybody aligned on what that discharge plan looks like so that we can reduce unnecessary ED visits and hospital readmissions again? Number 7, the frequency of dropped care per 1,000 transitions. And number 8 is the number of scheduled appointments where the patient was referred to a new point of care or provider. Okay, next slide, please. On slide 25, what we do here is talk about that third vertical, which is our member enrollment and engagement. And what we've really emphasized here is that the social diversity of Central Health's patients really requires a tailored approach to engage with our patients. So we've identified 4 strategic priorities to achieve this goal. Number 1, enhance language and culturally appropriate outreach. Number 2, improve enrollment through screening and identification of appropriate programs. Number 3, improve education and awareness of the types of programs and the utilization of services that are available. And number 4 is empower patients to seek out care once they are engaged so that they can remain active in their own care delivery process. So moving to the right column and really drilling down on what are the actions that we need to take to really achieve success and fulfill these strategic priorities. Number 1, increase the duration of the enrollment period. So making it a little bit easier for patients to enroll in our programs. Number 2, deploying centralized help desks with multilingual staff to answer patient questions. So really providing those resources to troubleshoot as patients look to enroll in programs. Number 3 is development of clinical and non-clinical staff to deliver culturally competent care, which is so important when we think about the social determinants of health that we reviewed last week and the diversity of our safety net population to really assure that we're delivering care in that culturally competent way and building trust with these patients. Number 4 is leveraging multi-channel technologies. We know that this is not a one-size-fits-all. And number 5 is expand health and wellness programs in the community. So how will we measure our performance? Number 1 is increasing the number of patient engagement education events and programs that we've offered. Number 2 is increasing the volume of multilingual and culturally appropriate printed materials that we have developed and can provide to our patients so that they're receiving information in a way that they understand and makes them comfortable. Number 3 is increasing the number of multilingual and culturally competent providers. Number 4 is increasing the percentage of eligible populations enrolled in our programs with timely access. And that goes hand in hand with number 5, which is aligning our capacity with the increase in incoming enrollment and appointment queries. And number 6 is decrease in the number of missed appointments. So when we think about access and capacity, which was discussed a few slides prior, and the fact that we have an opportunity to nearly double our enrollment, it's so important that we align the strategic priorities for our member engagement with access and capacity to assure that these members have access to the services that they're eligible for. Next slide, please. So when we think about the system of care on slide 26, really what we'd like to do is optimize our partner portfolio and contractual agreements so that we can execute on a central system-based strategy. So what does that really mean in terms of strategic priorities? So number one would be to bolster and encourage the strategic and effective use of capital. So where are we going to invest to make the most impact? Number two would be to recalibrate and redesign the scale and scope of Central Health's dependence on partners. Number three is to create an inclusive and accountable governance model for the system of care. And number four is to enhance the coordinated use of Central Health's assets and partners. So really to reduce the duplication of efforts and be more efficient and effective as we deliver care to the safety net community. So the actions that we need to take to achieve these strategic priorities extend across 5 main domains. Number one is to identify the gaps in the system of care and determine areas of highest need. Number two would be to assess operations to identify and leverage system synergies and complementaries. Number three is to design systems to track cost of care. Number four would be to collaborate on the design and alignment around centralized models. And lastly, establishing financial and operational benchmarks that will guide system performance. How will we measure our success? So number one, increase quality or access to demonstrate value of capital expenditure. So for example, that would be on initiatives, agreements, specialty services, etc. Number two is the number of specialties and services that are exclusively available at less than 2 partners, affiliates, or contracted organizations. And number three is the number of services expanding or enhancing programs and initiatives that come out of collaborative alignment meetings. Okay. Next slide, please. Okay, Abby, do you want to close this out?
Yep, absolutely. So as a follow-up to this meeting, we have another meeting just for questions and answers related to what we presented today. And I think our goal today was to share the strategic plan with you. And I think it's extremely important for us to understand the magnitude and urgency of what we need to do. So there are a lot of things that we need to do, and there are a lot of areas that we need to focus on. And for that, being extremely strategic about what we put our time and money into is going to be important. So again, next steps would be for us to receive written questions, and then for the February 15 meeting to answer those questions and answers, which would again be followed by February 23rd, a meeting to review and adopt the equity-focused service delivery strategic plan. I'll open it up to questions or comments now.
So managers, there's no motion necessary, but if anyone has a question that is stays pretty prevalent to this particular meeting that we've had today. Otherwise, if you have a more past questions for other meetings, please write them down and send them to the staff. But does anyone have a question over today's meeting? Yes, Manager Motwani.
Thank you, Dr. Britson. It is, I heard that there was going to be another meeting for Q&A, and I don't know. I mean, I have a sort of a theoretical question that does apply to this presentation. I don't know sort of the bigger picture on time for this meeting. Do you recommend that I save my question for a Q&A type meeting or launch it here? I want to get a general feel for the intent and what you have like sort of on the agenda.
Well, if you have a question here for today's meeting, some of the information that was presented, I would ask those questions today. If it is something that needs more elaboration by the staff, then they can also review it again at our next meeting.
That makes sense. I'll just follow staff and Guidehouse and your guidance. My question is kind of a high level, as I mentioned. The question is, when we have sort of gaps or opportunities in care, and I know that you all were, we've characterized some of the gaps, like say in specialty, dental, a few others, obviously, that are all salient, but as large gaps. And then some of the gaps, say in primary, were moderate. And of course, one of the slides that we saw today, as well as last week, you'll have a really specific, it's really great. It's not good news, but it's a really great breakdown of within each of the specialty areas or within each of the areas of care, sort of what we have in inventory, if you will, as far as the assets are concerned, and the professionals and the providers are concerned, and what we actually need. How do you weigh that against each other as far as what the highest need is? For example, if we're 30% off on primary care physicians and we're 30% off on element Y, does that mean that there's an equal amount of need between those two? What is the calculus sort of that you all use to weigh them against each other? I don't assume it's 1-to-1, and it's just a flat percentage deficit kind of thing. And again, if that's a large sort of moral framework question, or I don't want to necessarily get into it, but if there's a quick and dirty, I would love to hear it.
So that's a great question. We have developed an analytical tool that allows us to prioritize gaps and needs. And just to provide a simple overview, it takes each gap and then asks the respondents to answer questions, which are then graded, and the score then drives what the level of effort to close that gap would be, and what the impact on unmet needs would be if we close that gap. So there is an analytic framework that allows us to go to a great level of detail and put data and institutional knowledge behind how we prioritize from within those different specialty areas and gaps.
Okay, great.
And we have a presentation for that as well, which
cool.
goes to the details of the insights of that tool.
So if I'm hearing it right, there's institutional weighting around, probably what mortality and morbidity outcomes are in the absence of a particular type of care. And then they're also weighted by the respondents and how, their responses may create indicators that will also weigh the value of those items in as much as closing gaps. Is that right?
That is correct. Yes, but each respondent, the answer that each respondent gives would carry the same weight, but the questions carry different weights. So as an example, if we were to think about the impact that a recommendation would have on closing a gap, we look at specific criteria. The first one is, does it improve access? The second one is, if it improves access, is it for 5 people or is it for 5,000? And then we also have things like member engagement. So if you think about these 3 alone, creating access would be weighted more than member engagement. I'm not saying that member engagement would not be weighted at all, but we have priority weights for different questions that allow us to put that analytic rigor behind how we are prioritizing from amongst these different options. Does that help?
Thank you, Chairperson.
Any other questions? Yes, Monica?
Chair Brunson, I noticed that Dr. Shalsha has come on screen, and I think that he might have a little bit more context to add to Manager Motwani's excellent question about the prioritization framework and factors. And then I think we also have Sarita Clark-Leach, who's on the call, who can add even some additional context to the equity focus and how that has come into all of this work. If Dr. Shalsha and Sarita could add a little bit more context.
Good afternoon. Thanks, Monica. Great question. And I think Abhi spoke perfectly to it. I think we also looked at kind of endpoints, disease state, and how making decisions now would affect kind of the long term. And so these multifaceted questions really then, also takes into consideration, I think, investment of staff and resources and kind of output, and then graphs everything in relation to each other. So, and then depending on, I think, the individual's perspective will depend on how they answer the questions, and that will then scale the output differently. So I think when we actually show those questions, it'll provide a much greater explanation, but really, really good question.
Hi, this is Sarita. And so, when we started off the meeting, we showed our population, what our population looks like from a geographical perspective. And that's often not a perspective that we think about when we're considering just our folks who are at or below 200% of the federal poverty income level. You usually see prevalence as it's distributed throughout the wider community. So everyone in Travis County, essentially. So it's really what the work that we did, shows is that once you hone into our folks who are, low income, that prevalence distribution looks a lot different, and it demonstrates needs in areas that weren't really recognized before, as this report continually points out. So certainly areas for opportunity and identification of populations that we don't usually think of in areas that need that additional clinical support because they do have high rates of prevalence. It's no longer just seen on the outer edges of East Travis County. We see that there's need in our central corridor as well. And then we have a small population out in Jonestown, Lago Vista, that is in need of support as well. So we're looking at the need in multifaceted ways.
Thank you. Do any other managers have any comments or questions? Oh, yes. Yes, Manager Jones.
Once again, I'd like to compliment you on this presentation. This was extremely one of the better ones I've seen in my many years here in trying to assess what we're dealing with here. So first, I'd like to start off by complimenting you. I know this is for this time, so I'll focus my questions around this presentation. I counted at least 4, maybe 5 times in which you talked about the lack of adequate providers, either currently or in our system as we go forth. My question goes to the fact that when we're looking at strategy and we're looking at how we use our taxpayer dollars to address the population we serve, embedded in that is the fact that we also support a medical institution. And so my question goes to the question as whether or not we calculate, or we should be calculating, what our expectations out of that investment to address these types of efficiencies that you have outlined here. Because I think it's unfair to our taxpayer citizens to say we have all these challenges still while we're supporting the investment and the education of medical professions in this community that may end up in other parts of the state, the nation, in other words. So I just think that we need to talk about strategy. How do we get some return on our investment there, at least for a short period of time upon completion, so that we can be able to address some of these deficiencies you've mentioned?
Yeah, that is a great question, Manager Jones. Thank you. So I'll take a first pass at responding. So kind of starting at the top. So we did consider the amount of time we're getting from those providers affiliated with the academic institution. So really understanding how much time are we getting from these providers dedicated to serving our members. So what we've found through this work is that we still have a road ahead to really position ourselves to effectively meet the healthcare needs of our safety net patients. So more work to be done. The path getting there is going to be multifold. And as we had mentioned, not a one size fits all, recognizing the fact that there is a national shortage of providers, across the United States. Travis County is not immune to that, unfortunately. So regardless of payer type, Travis County has a shortage of physicians. So what that's going to require is creative solutions as you move into this next phase of implementation planning to really design ways that we can expand access, being mindful that we have a shortage of providers. With that said, through the contracts with Dell Medical and other provider organizations, really kind of looking at those and incentivizing, when we talked about aligning incentives across provider organizations, across the system of care, to really assuring that we're working towards the same goal. Does that provide the clarity?
Yes,
Nope.
yes, that's very helpful. I just think at some point as a board, we're going to really have to assess this question in a greater approach. But that was very helpful, and I appreciate your response. I have one other question, but can I ask it now, Manager Brent, or should I wait?
Just to add to that, Manager Jones,
I'm sorry.
As we move to the future, we'll have to take a lot of tough decisions, and this is one of those, right? It gets to the core of being a responsible user of public funds. So as we think about using capital in a more efficient way, the decision around what we are getting out of paying money to UT Dell versus if we don't pay them, how does this translate to better access and care is going to be a key decision that needs to be taken. And eventually it goes back to whether we decide to provide services directly, whether we decide to operate services for someone else, or whether we contract with a new entity or continue our contract with UT Dell so that some of these needs are met. So again, really good question. And this is, I think, at the core of what we need to do as we think about future planning. Does that help?
Yes, yes, very much. Manager Brunson, can I just ask one other question which piggybacks off of this one?
Yes, go ahead, Manager Jones.
I'll make it sort of quickly, because it goes to what you just said, Dr. Sharma, somewhat in terms of the system that we currently have here is a unique system in Texas in terms of how we have our district. And I think that has to be embedded in this discussion as well as we look strategically down the road, 5, 10, 15, whatever, many years down the road. Because with these challenges we face, if indeed our provider base is not growing and we're contributing to a base that is not coming to us at some point we have to ask the question, is it better that we look at doing this ourselves or cost beneficial versus continuing this model, which on one hand says it's efficient, but on the other hand, it's really not meeting the needs and it's going to be increasingly more expensive. So those are just my comments. Thanks very much for the opportunity.
Thank you. Thank you all for the very thought-provoking questions. And I hope very much that the managers continue to ask the questions they really need to know to help us make these decisions. So any questions you have, please send them on to the staff so that they can work on getting us our answers for next meeting next week.
Madam
So,
Chair?
Yes.
Madam Chair, I think I would, even though you couldn't hear me, I apologize for that. Since you began to ask questions, I've tried to access and be able to make some comments very quickly.
Okay, go ahead. Go ahead, Manager Valdez.
Thank you, thank you, Madam Chair. I want to thank you all for providing more confirmation to what we have been, many of us in the community have been saying for 6, 7, 8 years. And I am so glad that you're putting pencil to paper to confirm that in black and white so that people can understand that. Thank you, Shannon, for bringing up the UT question that I have been asking for 7 years. And thank you, Amit, for bringing up the question on the weighting and the measuring of the analyzing the data and the information that they're receiving. To that, Dr. Sharma, are you going to provide us, because I would like this, and I have been asking for this, I would like to have a copy of that analytical tool that you're using to look at the information that you're receiving. It has not been provided. I've said so in the comments, the 2-page comments that I submitted right before this meeting. So we can answer that later, but I would like to receive that tool. Are you going to provide it to us? Hello?
So, yeah, I can take that. So we will hand it over to Central Health, and Monica and Mike. I'm not sure whether Manager Valdez would have access to it if we just send it to you.
I would hope that if you sent it to Central Health, they would distribute it to all our board members. I would think that they would be interested, but at the very least, I am. So if you could make sure that I get a copy, I'd appreciate it. Another thing, as you're looking at an interdisciplinary and joint effort to address and close the disparities gap, one of the suggestions that I have made for many years now that has yet to occur is that we at Central Health serve as the entity that calls all the governmental agencies together, or that we go and meet with them because they already have an organization in place. All representatives from all the government agencies are already meeting. They meet at the Travis County, they meet at the City Hall, they meet at different places. And I would like for Central Health to be a participant. I've said that and advertised and prayed for that for many years now. This is the reason why, because we have to work with the other agencies, especially our educational and behavioral health entities, to begin to serve the needs that we see arise from the moment the children are born. And we can't do that if we're not working with the school system to provide, to get them to provide health literacy so that our families can be empowered to be able to advocate for themselves. These are not new suggestions. They are suggestions that have been provided for asked for at least 20 years in different communities of poverty and people of color and ethnicity when they're trying to close the disparities gap so that they can have a greater quality of life. And a way to look at that is to be at the table with the school systems. We have 17 school systems in Travis County. We should be meeting with all of them to help
Manager Valdez, thank you so much for this. We would like to end this meeting by 3:15. So if we can move forward.
Madam Chair, if she could conclude her question, I'm happy to address that.
Oh,
Thank you, Mike. Okay, so the point is for us as a board, I would like for us as a board to work with our staff and especially our CEO, who I know knows exactly what I'm talking about. We've had many conversations, and show that this is a major point for closing the disparities gaps jointly with the other government entities in Travis County. And I want to thank you, Dr. Shermy, for consenting to provide that equity analytical tool. And I'll write some more to be submitted for next week's questions. Thank you.
So, Manager Valdez, in response to your question, the good news is that there already is a lot of cross-agency and cross-organizational collaboration and communication. So much that's we allocate a lot of time to that. And a lot of times it's a lot of the same people in the same meetings even.
That's right.
And what we have been doing as we're going through this process is letting our partners know that this analysis and this strategic services delivery plan as part of the equity focused systems delivery work is coming. And it's going to really bring about impactful change within the community. That's going to involve a number of partners. Now, this is obviously an iterative process. It's going to take several months to tee up and then years to implement. But the good news is that those communications have been happening long before this, and those will continue to happen as they need to. Thank you. Thank you, Madam Chair.
thank you. Thank you so much. All right. So, managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Tuesday, February the 15th, 2022 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Madam, yes, thank you. And a second?
Second,
Yes,
Cynthia.
thank you, Dr. Bell. Yes. Yes, thank you. Okay, thank you so much. We are adjourned.
Thank you.
Thank you, members.